Hello and welcome to a Health Podyssey. I'm your host, not Alan Weil. I know what you're thinking. That's not Alan Weil. And you're right. It's true. My name is not Alan Weil. It's Rob Lott. I am a longtime deputy editor at Health Affairs, an even longer time veteran of the health policy trenches. And I'm honored and a little nervous, I admit, to be taking the reins of this podcast. Your old host, Alan, our editor-in-chief of 10 years, my former boss and still mentor, Alan, recently stepped down from Health Affairs to take on a new role as Senior Vice President for Public Policy at AARP. We're really thrilled for him and really sad to see him go. Alan was a Health Podyssey's heart and soul, its driving force for more than 200 episodes, engaging authors and providing them an opportunity to lift up their own work, taking it from the page and making it real for listeners in new ways. I'm grateful for what I learned listening to those conversations, and I know I'm not alone. So thank you, Alan, for giving us a Health Podyssey. And thank you all for the opportunity to keep it going. To our listeners, as your new host, all I can say is that I promise to give it my all, to be open to difficult questions and surprising ideas, and to stay curious. I hope you will find my conversations as interesting and illuminating as I found Alan's to be. And with that, I'm going to ask our producer to be kind, rewind, and restart the intro music cue. Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. The last few years have seen a surge in the use of artificial intelligence and machine learning in healthcare. Over that same period, we've also seen a surge in the capacity of those tools to push the bounds of what's possible, technologically, clinically, and ethically. Along the way, more and more hospitals are embedding these tools in their day-to-day processes. It's all quite promising and maybe a little scary too, especially because we don't have a clear or systematically documented picture of who's doing what and how. How are artificial intelligence and machine learning currently being used in U.S. hospitals? And among those institutions that are using these tools, how are they assessing their accuracy, their benefit, and their potential bias? That's the topic of today's Health Podyssey. I'm here with the brilliant Paige Nong, assistant professor at the University of Minnesota School of Public Health. Dr. Nong and co-authors published a paper in the January 2024 issue of Health Affairs titled Current Use and Evaluation of Artificial Intelligence and Predictive Models in U.S. Hospitals. And I'm eager to ask her all about it. Paige, welcome to the program.
Thank you so much for having me. I'm really excited to be here.
So I think most people have a vague idea of what artificial intelligence and machine learning are, but also maybe a hard time pointing to specific examples beyond maybe just ChatGPT or HAL 3000 and A Space Odyssey. And so why don't we start there? What does AI look like in real life? And let's use healthcare, obviously, as our lens. When we talk about AI in the healthcare space, what are we actually talking about in practical terms? How is AI and machine learning being applied day to day in the healthcare space?
This is a great question. And I think there's an admittedly simplified but pretty useful framing for thinking about this. So we can kind of broadly bucket AI into two categories, predictive AI and generative AI. Of course, in reality, it's not an entirely dichotomous methodological distinction, but it helps to understand what's actually happening practically in the healthcare system. So predictive AI models are trained on data to identify patterns and then make predictions based on those patterns. So this can be computationally pretty straightforward or very complex. There's a whole spectrum. But in practice, predictive AI can be used to predict sepsis or to predict inpatient fall risk for patients in the hospital. It can also be used for operational or administrative purposes like scheduling and billing. On the generative AI side, what it does is it uses pattern recognition and prediction too, but it's different in that it produces new text or images. So this is the category of AI that ChatGPT falls into. In healthcare, this kind of AI is being used for ambient scribes and documentation to produce clinical notes, for example, to transcribe clinical encounters. In terms of how predictive AI is being used on a day-to-day basis in healthcare, we knew from the literature that it was being used for various clinical purposes, like predicting sepsis. That's a famous one. And we knew it was being applied to non-clinical aspects of healthcare, like billing and scheduling, but we didn't actually have an empirical understanding at the national level of what predictive AI use looked like and how it was being evaluated before we analyzed the survey data.
Great. So let's go ahead and turn to your article, which really does attempt to paint a picture of how hospitals are using these tools. Can you say a little bit about how you approached the task? What tool did you use to measure or really quantify the state of play?
Yes, absolutely. I'd like to start off first by highlighting my co-authors, Doctors Julia Adler-Milstein, Nate Apathy, AJ Holmgren, and Jordan Everson. This was a great collaboration and team effort, and they were fantastic thought partners in this work. Jordan Everson, in particular, is at the Office of the Assistant Secretary for Technology Policy, or ASTP, which is part of HHS. So he and his colleagues at ASTP worked with the American Hospital Association to collect national data on the use and evaluation of predictive AI in hospitals across the country as part of their annual survey. So there's a component of that survey called the IT supplement that focuses on hospital technology capabilities and practices. And the survey is sent to all hospital CEOs across the country on an annual basis to provide important information about their operations and IT use. So for the first time in 2023, the survey instrument included questions about machine learning and predictive model use, the applications of these tools, their developers, and really importantly, local evaluation practices.
Wow, that's pretty exciting. What did you find?
We found that 65% of US hospitals are using some kind of machine learning or other predictive models that display in their electronic health record. Most often, these tools are used for risk prediction, for early detection of things like sepsis, or predicting inpatient fall risks. The second most common application is identifying high-risk patients for follow-up care. So that would include predictive models to predict readmission risk, for example. The third most common application of predictive AI in US hospitals was to facilitate scheduling. So that speaks to that kind of operational or administrative application of the technology that I mentioned earlier. It was really interesting to see this distribution of predictive AI use in the healthcare system. I think there's often an assumption that these tools are being used specifically to diagnose patients or to recommend treatments. And we do see some of that. But the most common applications are risk prediction, early disease detection, and scheduling.
I think I have a sense of what you're describing, but I guess one question that I keep coming back to is sort of how these tools are chosen and implemented. Are hospitals proactively seeking them out to solve a specific problem? Or is it more like a vendor comes to a hospital and says, "Have I got a tool for you?" What's the typical back and forth there?
So the ideal would be the former, right? We don't want to be sort of walking around with this technology in search of a problem we can apply it to. The goal in good AI governance is to have a problem and to identify the right tool to fix that problem. Right? So that's what we want to see. What we see in the survey is that 79% of the hospitals using these tools are getting them from their EHR vendor. That's the most common source of predictive models for US hospitals. But 59% of the hospitals using the tools are getting them from a third-party developer, and almost as many are self-developing them. So it's a combination of external sources and internal development. Some hospitals are not only going to a vendor seeking a tool, but actually designing their own which of course is dependent on their internal resources and capabilities. But they are often designing their own tools. In terms of what decision making looks like on the ground, I can describe from some of my qualitative work how hospitals are kind of working through these decisions, because the survey just can't quite capture what this process looks like. Hospitals do seek out these tools to solve specific problems, but they are also getting some pretty impressive pitches from vendors about how these tools will transform their operations or change clinical decision making. And there is a lot of work to do to sort out which tools are effective and to understand how and why. That's where I see a lot of value in the HTI-1 rule from ASTP, actually. The guidelines that they've put forward about transparency for predictive tools are a really great policy foundation for these hospitals as they're trying to think about vendor claims and their own priorities and needs and prioritizing patient safety. They really need information about the tools to make good decisions.
Great. What I hear you saying at the sort of baseline is that not all tools are created equal. And I look forward to asking you a little more about that after a break. And we're back. I'm here with Dr. Paige Nong, and lots to learn about AI in American hospitals today. Dr. Nong, in a field like this that's still really quite young, obviously some tools are going to be more effective or useful in doing what they promise compared to others. So here's another two-part question for you. Who is actually evaluating these tools, and how are they doing that?
Yes, it's a good point. AI is a very broad umbrella term that means a lot of different things to a lot of different people. And even if it seems like a great solution for a longstanding problem, we need evidence to determine if that's true in practice. That's part of why local evaluation of predictive AI is so important. The tools don't often translate well. Plug and play is not a best practice because of differences in patient populations and data capture, infrastructure, and healthcare practices. So what works well in one setting might not work at all or might perform poorly in another setting. So we know it's important to do this local evaluation to see how a model actually operates in the patient population for which it's going to be used. But before this analysis, we didn't know how often local evaluation was happening. So we found that among hospitals using predictive AI, 61% say that they're locally evaluating most or all of their predictive tools for accuracy. But only 44% report conducting that kind of local evaluation for bias. And we've seen in the literature how these tools can operate sort of unfairly or how they can exhibit bias. So this indicates to us a really important point for policy intervention and also practice change to make sure that we're doing a better job across the country of conducting local evaluation for bias.
Great. And when you say bias, I know there's been many other papers written on this topic, but just briefly, that's the idea that a predictive model might treat a racial or ethnic minority differently, or those that population might not benefit in the same way from a different population when they're the subject of that model. Is that fair?
Yes, that's right. And what you want to see when you're evaluating a model like this with local data is you want to look and make sure that the tool performs not just well, but equally well across populations. That's really what this kind of local evaluation for bias is looking for. And it's critically important when a hospital is considering a tool for their own patients.
Okay, so just as these tools can really vary, we also know that not all hospitals are the same, obviously. And I'm curious if you noted any disparities in terms of how different hospitals approach these tools.
Yes, we did. We saw differences across hospital types in both the use and the evaluation of predictive AI. So for hospitals that were system members and hospitals with higher operating margins, they were more likely to both use and evaluate predictive AI than other hospitals. Rural hospitals were less likely to do so. So there's a gap there in the use of the technology and the frequency of local evaluation. We didn't actually observe any differences based on a hospital's teaching status, but we do see a relationship between hospital size and the use of predictive AI, where larger hospitals are more likely to use the tools. Critical access hospitals and hospitals with a high area social deprivation index were less likely to use predictive AI. So taken kind of all together, what this signals is that access to resources is a really important factor in a hospital's ability to follow those best practices and robustly evaluate the tools that they're using.
Wow. So let's say my priority is health equity. What are the implications for those disparities for anyone interested in advancing equity across health systems? And conversely, how might these disparities affect underserved or historically marginalized populations?
Yeah, so these systematic differences across hospitals show us what we call an organizational digital divide, right? It's an inequality at the organization level where patients and clinicians at some hospitals might not benefit from the potential value of fair and effective AI, while others do. Right? This is not what we want the healthcare AI landscape to look like because it can widen existing disparities and exacerbate existing challenges that we already have in the healthcare system. When we think about the potential value of AI, what we want it to do is to help us solve those existing problems, right? We talked about this as a best governance practice at the organization level, but healthcare system wide, we really want to be thoughtful and careful about how we use the technology to actually address our problems and avoid the exacerbation of our existing challenges. So our primary concern here with this digital divide idea is that if some hospitals are able to conduct this robust evaluation for accuracy and bias, and others aren't, it might result in systematic differences in the quality of the AI tools that are deployed for different patient populations, which can result in negative consequences across that continuum of care, right? If we're thinking about scheduling or billing, or we're thinking about detecting sepsis or predicting fall risk, we want to make sure that across that continuum, we're ensuring that that patients are equally kept safe and that these tools are effective and ethical.
Paige, a lot of commentary about AI in healthcare sort of veers towards the extremes. You've got boosterism on one side and sort of a doomsday take on the other. And I imagine you're probably somewhere in between. But tell us, based on your experience as a researcher in this space, how would you, as an individual healthcare consumer, approach this? Let's say you're about to receive care at a hospital, you're walking in the door, and how are you thinking about this on a scale of 1 to 10? If 1 is, thank God this hospital has a robust AI system in place, and 10 is like a dark fear that we're on the path to being ruled by evil robot doctors. How are you thinking about it when you're walking in the door?
I would say I definitely don't fall on either end of the spectrum, but it really does depend almost entirely on where and how the AI is being used along that care continuum. So if it's being used to make documentation easier for my clinician and there are robust quality checks in place, I might not worry. If it's being used to triage phone calls to the front desk, but I have a direct human alternative if I want one, I'm also not worried. On the clinical side, I think there are also mechanisms for review and some long-standing guardrails. So truthfully, I worry a little less about clinical applications of AI just because we have some better infrastructure in place to guide those decisions about how we use those tools, right? I'm actually a little bit more worried about that operational and administrative side of things. It turns out that the US public shares these concerns. We did a national public survey and found that people are more concerned about predicting missed appointments and paying bills than they are about those clinical applications like predicting colon cancer or sepsis. I think a lot about people who've missed a few appointments in the past being prevented from scheduling a new appointment with their clinician, or having their appointment slot double booked and having no idea why or how it happened. I worry about people being sent to collections agencies faster because their predicted propensity to pay their bill was relatively low. So I think a lot about those tools that are operating behind the scenes where they really matter for patient experience of the healthcare system, where patients' experiences could become increasingly negative or challenging, but they're not actually told why. So we found in our paper that half of hospitals using predictive tools are using them for scheduling, and 36% are using them for billing. So I think we have a lot of work to do to make sure that the decisions being made with these tools aren't punishing patients or operating unfairly. That's a real priority for me in my work, not just thinking about receiving care, but also on the research and policy side. How can we make sure these tools operate safely, effectively, and accurately from a methodological standpoint, but also the ethical and equity implications of how these tools affect patients?
Well, that's a great segue actually for my next question, which is really to acknowledge the role of policymakers in sort of confronting or addressing that risk. And let's do another hypothetical. Let's say that the new Congress is coming to session and the Senate Health Committee has called a hearing on AI in hospital care. The panel includes a hospital CEO and a patient advocate, let's say. And the first senator asked the same question of both of the witnesses. What's the most important policy change you'd like to see when it comes to AI in healthcare? Can you put yourself in the shoes of the hospital CEO and the patient advocate? What do you think they're most likely to say?
Yes. So, in some qualitative interviews that I've done with hospital leadership, like CEOs and chief medical information officers, I've heard some variation. I would say one consistent theme is a desire for specificity around regulation and some clear guardrails for safe, effective, and fair AI. These stakeholders are often working really hard to figure out how they're going to govern AI in their organizations. They're trying to determine policies and practices internally. And I often hear that they're looking for clear guidance. So I think HTI-1 from ASTP makes huge strides in that direction. And building on that foundation for these hospital stakeholders would be highly responsive to their needs. There's one caveat that I think it would depend on what kind of hospital that CEO was representing, right? Because based on our analysis of the survey data, there are real differences in resources and capabilities across types of hospitals. So a large academic medical center with a big IT team that has the capability to design their own predictive AI tools might say, you know what, we could really benefit from specific regulation and guidelines. Whereas an under-resourced hospital in a high area social deprivation index would agree, but also say that resources and technical capacity are really critical for them to be able to do a good job of evaluating the AI tools that they use. So I think there could be some differences in perspectives, but the unifying theme is kind of a desire for specificity and additional guidance as the landscape evolves. On the patient side, my work analyzing national public surveys with Jody Platt and Sharon Cardia, we've been doing this for years. And what we see over and over again in these national surveys is a strong desire for notification. People want to be told when these tools are used in their care. So I could see a patient advocate drawing on this kind of evidence from national surveys, saying that notification and transparency should be kind of baseline requirements for AI use in healthcare.
Great. Well, before we wrap up, I'd love to hear a little bit about how you got here, Paige. You're at a relatively early stage in your career, and I'd love to hear a little bit about how you came to focus on AI in healthcare and where you see it leading in terms of maybe future research questions for you and your colleagues.
Yeah, so I was introduced to the IT policy world actually back in the Meaningful Use days in 2013, working with Julia Adler-Milstein as part of her health IT lab. The national focus at the time was how do we use electronic health records effectively and transition away from faxing. So I was conducting interviews in primary care practices across the state, often hearing about these clinicians receiving summary of care reports via fax. So the seeds of the work that I do now were planted quite a long time ago. But that work really evolved as I was seeing how predictive tools were starting to take shape years ago. And I was deeply curious about how health systems were going to adapt. I really wanted to know what policy would look like around these predictive tools and how they would impact patients in the context of structural inequities in our healthcare system. So that's been the focus of my research for, I think, more than 5 years now. In terms of next steps, my colleagues and I definitely have our work cut out for us. Building on the paper we talked about today, we have new national data to analyze, and we're looking at more applications of AI, including generative AI, which presents some interesting governance questions and challenges. So we have some exciting work ahead of us.
You sure do. And here's hoping we'll get to see that work soon and maybe have you back here on a Health Podyssey to talk about it. Dr. Nong, thank you again for taking the time to chat with us.
Thank you so much for having me. This was great.
And thank you to our listeners for joining us on a Health Podyssey. If you enjoyed it, please tell a friend and tune in next week.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.